Thank you everyone for coming. We weren't expecting this overwhelming response actually for something that really started as sort of an informal chat. So just to introduce myself, if for those of you who don't know me,
it's crazy.
My name is Jeffrey Franc. I'm a clinical professor of emergency medicine at the University of Alberta, and I'm a visiting professor in disaster medicine at the University UPO in Novara, Italy, which is about 50 kilometers outside of Milan. I have a master's degree in disaster medicine, and I was the AHS medical director for emergency disaster management from 2010 to 2015. So I'll let Manuela introduce herself.
Hello everyone, I'm Manuela Verde. I'm from the UPO, University of Piemonte Orientale in Novara, Italy. I'm a specialist in anesthesia and intensive care, and I have a master's degree in disaster medicine. I'm faculty at the European Master in Disaster Medicine Novara in Brussels, and I'm also a researcher at the Center for
Are you in the middle of a meeting?
Disaster Medicine.
I have to finish something.
Yeah, no worries.
And then maybe I'll come.
Sure.
Okay. So just a quick, like I said, we weren't really anticipating this level of participation in the talk. I want to say at the outset, this is designed as a very informal event. We are not AHS sanctioned for this program, okay? So nothing we say here is official AHS information. What we're presenting actually is kind of anecdotal information that we've collected. Mostly it's here not to set any guidelines, but just to give a more human aspect of what's going on in Italy, okay? So we don't have any slides. We're not going to talk about epidemiology. We're going to talk for probably about 20 minutes, and then we'll have some time to answer some questions. If you have questions as we're going along or concerns, please just pop them in the chat message and we'll be happy to try to address them. We have a few questions that came up by email. We'll address them at the end of the talk. The other thing is just to warn everybody, we are here with our two kids who are not in school, so they make a sudden appearance at any given time. So they're plugged into an iPad, so we're hoping for the best. Okay, so what we're going to talk about basically is sort of four things we wanted to talk about. One was the situation revolving PPE, which I think is a really scary thing for all of us. Talk a little bit about clinical pathways, talk a little bit about non-invasive ventilation and what we're seeing the role of in Italy, and then we'll talk a little bit about staff issues, mostly again from the sort of more humanistic point of views. So I think the most common question I get asked is about PPE and how are people in Italy protecting themselves. There's sort of, we have two pieces of information. We have the actual guidelines, and then we have some anecdotal evidence of what's going on. The actual guidelines were just released about 2 days ago, I think, 2 or 3 days ago, Manuela?
Yes,
4 days ago. And they're actually very similar to the existing AHS guidelines, okay, with basically contact droplet precautions for most physician encounters with COVID positive patients and aerosol precautions for when you're doing aerosol generating procedures. Anecdotally, we're seeing a big range of what people are using for PPE, right up to and involving what we would consider the N99 masks and the full Ebola type outfit. Okay. There is for sure in Italy a shortage of PPE, and that is becoming a major problem. When I spoke with my director at the ICU in Novara, he was very concerned because they have a shortage of PPE. There appears to be sort of two things that are driving the shortage. One is that he says people don't have faith in the guidelines. And I think one of the things that's very difficult is that people are seeing the official Italian guidelines, they're seeing the CDC guidelines, the WHO guidelines, and 400 other people who are on Twitter with their guidelines. And so people are very scared about the guidelines, so they're overusing the PPE. There are also anecdotes about a fair amount of PPE going missing, which probably involves some combination of the patients and the staff taking the PPE out of the hospital. What we do know is that the data initially on suggests that probably one of the major issues is that healthcare providers are getting infected due to poor use of PPE at the very outset when they're first having that initial phase of contact with the patients. PPE is being used by EMS at all times in Italy, and basically similar to what we do here. I did know that one of my colleagues from the University of Toronto, Lori Mazurek, I'm not sure if anyone saw her email that's been floating around talking about PPE preservation and cleaning and her experience in the SARS events with that. And I think that's served as sort of a useful document for all of us. So that sort of sums up what we've seen so far in the PPE. And I'll let anyone have questions right now about the PPE aspects?
You have 3 blueberries.
Just pop them up in the chat if anyone's interested or has concerns. Otherwise, I'm going to let Manuela talk a little bit about the clinical pathways that have been developed for these patients, because I think all of us are a bit scared, and since certainly no one in our province has experience dealing with these patients, these clinical pathways could come in pretty handy.
Yes, let me start first of all by saying that Lombardia, which is the epicenter of the outbreak in Italy, is in Veneto as well. They're very unique regions in the north of Italy, and they're 2 of the richest regions in Italy and in Europe in general. There's a very high density for population. We're talking 200 people per square kilometer. And there's a high concentration of healthcare resources too. Now, the fact that bad political decisions, such as closing peripheral hospitals, decreasing numbers of beds in the departments, and do everything they could to delay and stop turnover for the retiring staff, may have contributed to lower the surge capacity. But this happened in the past 15, 20 years. I mean, it's not something that was fixable in the immediate. But let me assure you that the standard of care is really high. What in general? What was really important was that right from the beginning, they realized how impactful this was going to be. So they decided to change their mindset completely to be open, and they started a coordinating network within the region. So all of the hospitals, the directors, the media manager, the epidemiology researchers, and everything, they started working from the beginning of the outbreak to augment as much as possible all the ICU capacity, because what was clear from the beginning was that what was needed in the end was ICU beds, mechanical ventilation. So so right away they started dividing. I mean, what didn't happen right away, and this might have translated into a high number of healthcare providers being infected. They didn't start the clean pathway and so-called dirty, they call it dirty pathway. So COVID negative and COVID positive. And it took 3 days to implement the pre-triage concept that I'm going to talk about in a bit. So it took them a little while to realize that they had to change their mindset completely. So the patient's predominant clinical picture is patient is symptomatic and suddenly starts desaturating, becomes dyspnoic, starts desaturating, and will have severe hypoxemia. But what they found out was that the lung compliance was very high, and they were responding very well to oxygen to therapy, including non-invasive ventilation. So what they did was trying to have a pre-triage area. This comes after 2 weeks from the outbreak, from a meeting, conference calls, and everything between all the heads of the emergency departments and intensive care units. So the patient is not accepted, is seen in a pre-triage area, and a nurse decides whether the patient has to go home or can access emergency, whether it's clean, like suspected COVID, or just there for lac repair, anything. But the nurse doesn't admit the patient. They just say, yes, you can go in, no, go home, and contact your general practitioner, your family primary care physician. So that is the first and foremost thing, most important thing that they established. They cannot afford to fill the emergency department. They cannot afford to waste, medical staff to admit and discharge patients few hours later. So they need this. So COVID negative, they go to the clean area, and then COVID positive, symptomatic, they go to the dirty area. They don't wait for the test results anymore. They just assume that everybody is COVID positive right now. So what they do is they start right away with SAT probe and a chest X-ray or ultrasound. They realize that chest ultrasound is more sensitive than chest X-ray, and almost as sensitive as chest CT scan, but ultrasound can be done at the patient's bedside. So and the CT scan is not infected or doesn't need to be sanitized afterwards. So they're keeping their CT scan clean. What they do is a walk test. A nurse does a walk test, which is like 25-30 meters in the hall of the emergency department, as fast as the patient can take it. And oxygen saturation is taken before the walk test and after the walk test. If the patient doesn't desaturate, the patient is sent home. Even if chest X-ray, chest ultrasound is positive, but the patient doesn't have desaturation, is sent home. The recommendation is buy yourself a SAT probe and do the walk test twice a day, and come back to the emergency department if you see a desaturation of 5 to 10%. So this is the first group. The second group is patient desaturate. So how much? That if they desaturate and their saturation still is between 90 and 94%, they are admitted in the green area. So we have star triage. We have green, yellow, and red area, red code patients. So these 90 to 94% after O2 SAT after walk test is a green patient. At this point, again, another nurse takes care of the patient, does all the necessary blood work, arterial gas analysis, and oxygen therapy to keep SATs higher than 94%. They recommend 15 liters of oxygen per minute with reservoir, and they notice that this changes. This usually is the patient responds well because there's a good lung compliance and there's not hypercapnia. So there's no problem of hypercapnia. So there's a good O2 therapy response. So we said blood work, arterial blood gas analysis, oxygen therapy, EKG, and it's a nurse who takes care of the patient in this phase. And if the patient responds well to oxygen therapy, the patient gets reassessed 6 hours later. 6 hours later. So if after 6 hours the patient is stable, has responded well to this oxygen therapy, the observation keeps going. If a patient after 6 hours of oxygen therapy has worsened and cannot keep his SATs higher than 90 or 94%, or even like usually 90%, they go in the third group and they become a red code. They evolve to red code. And CPAP, so non-invasive ventilation, is started right away. They recommend early start of non-invasive ventilation because they respond well to high peaks, 10 centimeters of water, and a FiO2 of 50 to 60 percent, because the high PEEP is needed because at the beginning of this presentation, the alveoli are the ones who collapse, so they want to keep them recruited, and there's a slight edema, so they want to avoid pulmonary atelectasis and consolidation of the infection. Yeah. Well, anyways, you know what I mean. So this group is also goes to join the group that desaturated after the walk test. So we said walk test, group 1 does not desaturate. Group 2 desaturates between 9 and 90 and 94%. So they do the oxygen therapy like with the reservoir. And group 3 desaturates over 10%, so becomes a red code. They say start an IV as early as possible, because if you wait, it just decreases the success of intubation anyways. And just so you know, they realize that 50% of these patients will require a tube anyways in the end. But because of the high surge of critical care patient, like patient needing critical care, intensive care, they want to keep as many patients out of the intensive care unit as possible. So I think this is all for the pathway.
I'll move on to talk about the.
Yes, yeah, oh yeah, and Jeff is going to talk about the non-invasive.
So we had a whole bunch of questions come up on the chat. For those of you who can't see the chat, most of them revolve around, or many of them revolve around the concept of non-invasive ventilation, which my understanding of the AHS pathway at this point is that we are to try to avoid non-invasive ventilation. There's a couple things I think to put in context. One is that these patients who go on to non-invasive ventilation form a massive part of the treatment. So I'm going to guess, please no quotes on this, but I'm going to guess from what I've seen that about 80% of the patients are treated with non-invasive ventilation. Okay, so and there is this evidence that it prevents early non-invasive ventilation, prevents basically, what they found is that if you wait for people to deteriorate to the point of needing intubation, by the time you intubate them, it's too late. And so what they're finding is that people who go on non-invasive ventilation, if they deteriorate and then they need intubation, they do much better. These units are basically dedicated units, and they are the staff who are in these, which are several of my colleagues and I've had contact with, have a relatively miserable shift when they come into work. They basically dress up in the full head-to-toe Ebola outfit, okay? So coverall, welder's shield. They use a PF3 mask, which is our N99 mask. And they have 6-hour shifts, and you do not get out of this suit for your 6 hours. You're basically inside this area, which of course is basically becomes an aerosol chamber for the virus. And that's basically it. They also use a lot of these helmets, which I have to say, until I went to Italy and saw an ICU, I'd never seen this thing. So those of you who work, I've never seen one at the U of A for sure. I'm not sure if anyone else in the province uses them. They're these, basically, they look like a fish bowl. They go over your head and they have a seal around here. They are also doing, so people who are put on these non-invasive ventilations are on them for a long period of time. People can be on them for weeks. And they're also doing some experiments with putting people prone in the non-invasive ventilation, or at least sitting. If you're younger, they sit you up. If you're older, they sedate you and put you prone. So I think this is something, I'm not sure which way things will go here, but I think it is important for everyone who's working on this to understand that this is something that they found in Italy to be necessary and useful, and it might be something that we want to think about worrying about now.
Verde is to protect the health and safety of all Canadians.
I'll let,
Do so.
there's still some of us who are off mute, and I can't tell if you're aiming that question at me or it's a side conversation. Okay, so Manuela is going to talk a little bit about some of the more anecdotal things, and particularly some of the experience that our friends, family, and colleagues have been through. Okay, so what you're going to get in this session is anecdotal evidence. So I caution all of you to avoid making dramatic conclusions from it. But I think it's important for us to talk a little bit about the human side.
Yes, what I did was first of all, I'm part of a group of Italian doctors and physicians on Facebook, but it's a really serious kind of group, and I have a lot of my fellow EMDMers on WhatsApp, and so I think I have the pulse on the situation. So I asked what would be the 5 top tips that could have made their life better if they had known what to expect. Like, how could you be better prepared? Like, what would you advise? So for sure, the top one thing was the PPE training and stocking. They all, from the community physicians to the intensive care physicians, so everybody complained a lack of training and a lack of stocking of PPE. They have to ration. Sorry, they have to ration their masks. They have to ration everything because there's not enough. And of course, every other country is keeping their stocks because they are expecting the same surge. So it's really hard to get PPE right now. So my colleagues say they feel as they were sent to war without a gun, because this exposes them to the risk of being infected, the risk of infecting their family. So speaking of family, this is something else that came up. They have issues, but I see that some of you are already on it, as in childcare. Childcare, kids are home from school, and our colleagues have to go to work. They're frontline, and who's taking care of the kids? So they wish there was something. Something had been in place beforehand, so that they didn't have to face the tsunami wave all at the same time. Something really important that came up was the legal shield that they needed, and for this, the Society of Anesthesiologists and Intensivists in Italy gave out wrote down a document, a paper, where they put black on white. They wrote down exactly all the guidelines and the choices that were going to be made. And this was really important for my colleagues because they felt backed up. They felt kind of their backs covered in case of patients or family members suing them for not doing enough. So the other thing was the psychological support. Psychological support, which is provided by psychiatrists who and clinical psychologists. Some of them. So clinical psychologists were already working within the hospital.
Tomorrow we have to talk to Rachel. You can just talk to Rachel, sweetheart. Like, I'll be with you though. We have to log on and do it like this, because she's not gonna see.
Provide some support for.
Okay, but it'll still be like you're seeing her. We'll just put you somewhere. Where would you feel comfortable? Would you feel comfortable turning
So
your
the other thing is
I thought so.
the lockdown. No one in Italy took the lockdown, and because the lack of adhering to governmental issued guidelines is probably what caused immense surge and it's going to produce some more results in the next few days. A lot of people from Milan moved back to southern Italy, and we're going to see like the incubation period is almost over. So we're going to see the effect on the southern Italian healthcare. So being locked down is stressful. It raises fears. It raises claustrophobia. People are allowed to go out for groceries, not shopping. They're allowed to go out for taking care of sick family members. They're allowed to go out for medical appointments or for physical exercise. But physical exercise has to be like not you meet your buddy and you go running together. Has to be isolated. You need to keep 3 feet social distance. Even my kids now know our kids now know the social. Yes, mommy, I took to the playground. Take them to the playground. Yes, mommy, I know. Social distance. Don't worry. So 3 feet between one another. When they drive a car, there cannot be more than 2 people in the same car, one, the driver, of course, and one in the back. Well, maybe when there's a Tesla. No.
Wow.
Yes. And there's police patrolling and stopping people, asking why they're out, and they say, and whatever excuse or whatever motivation you produce, they will control. They will check it. They will call your employer. I always need sorry. Employer. They will call the medical office, and they will look at the grocery shopping receipt. So physical exercise, they say. So my colleagues are actually recommending against overtraining, because this could impact the immune system and the inflammatory response. And they also
leading to
Yeah.
cardiomyopathy, which is something that apparently they're seeing in patients who initially get better from the reoxygenation
Yes.
point of view and then later develop cardiomyopathy.
because they're seeing this in young patients who are fit and generally like were running or do bike riding until the day before. So bike riding is another thing. They say, please don't go riding your bike to avoid trauma, to avoid having to go to the emergency department. Yes, so
Can you talk about maybe with your brother's experience with this?
oh yes, so many staff. Oh, okay. So many staff are being repurposed. So repurposing of the staff is happening in hospital. Like I said before, all hospitals needed to come together in a region. They came together. They formed a network. They decided which hospitals were going to be COVID positive hubs. My brother is a cardiologist in Milan, and he works in a COVID plus hub, a very big hospital, and they repurposed him to the non-invasive ventilation unit. Thank you. So he's learning non-invasive ventilation for the first time. I'm helping him. I'm trying to give support. So this is really stressful. This is another stressful thing that they had to go through. And
Can you talk about your friends' questions
Oh,
about
yes.
the quarantine
My,
process
my
and the lack of guidance about what to do when you're under quarantine?
Exactly. So there's a lot of questions on that Facebook group. It's only for physicians, and there's no dilly dally. It's just to put us all together and ask questions and give answers. So a lot of physicians, colleagues who have family members at home, they do not know what to do. There's no clear guidelines on how to self-quarantine in their own households. They are afraid, like I said, to infect their family members. And there's another thing, like I said before, it was clear from the beginning that this was an intensivist issue. So there's a lot of physicians who feel like they're not helping enough. That's why psychiatrists, for instance, they're offering psych support. And one of my friends, she's a neurosurgeon, and she has a 6-month-old baby, and she feels helpless, but most of all, she feels guilty because she's staying at home with her daughter at the same, but she would like to help because some of her colleagues are getting sick. But at the same time, she says, I cannot take my daughter to my parents because that's childcare. In Italy, and I suspect this is the main problem with all the high case fatality rate in Italy. A lot of people who probably came in contact with sick kids. I don't know if
The grandparents.
the grandparents.
Grandparents are a big reservoir for, we just have this idea in our head. We have no epidemiologic proof of it. One of the things is that childcare is grandparents, and so when they put the city of Milan on lockdown, they take the children and immediately they go live with their grandparents. So, and I think one of the interesting things was really the lack of, at least in Italy, there was a lack of guidance on the quarantine process. Who can you talk to? Do you have to live in your own room, or are you allowed to talk to the members in your household? So I think with that, we're going to kind of drop off with our little presentation. Sorry, I said 20 minutes, but it was 40 actually. But we have a couple of the questions. There's a whole lot of very clinical questions on here about chloroquine, steroids. I think we'll hold off on answering them. I'm not sure this is really the best forum for that. If anyone wants to know our experience, we'll probably get you to send either myself or Manuela an email, and we can talk a little bit more about that. If you want to give a brief 2-sentence summary of what they found does and doesn't work.
They found that steroids are not the best choice because the picture of these patients is
They're leukopenic.
Leukopenic and yes,
And immunosuppressed.
Immunosuppressed. So they're holding off on the steroids until they are really, I would say, end stage intensive in the intensive care already. So no steroids in the emergency department.
Unless they're patients who need steroids for other things or are on them.
Thank
So
you.
if you're already on steroids, or if you need steroids for a COPD exacerbation, then they're permitting that, from what I understand.
Yes.
Again, I just want to caution everybody who's listening to us, we're giving you anecdotal information, okay? Just what we've seen.
What we've read
What
on papers there. But papers are coming up all the time, every day, some conflicting, contrasting evidence. For instance, ACE inhibitors, you might have heard about it. I don't know if you have a clear idea. At the beginning, because they noticed that the virus interferes with the ACE receptors, they were thinking ACE inhibitors were bad. But then some studies showed that actually
some studies recommend the use of ACE inhibitors. So now they say, don't touch patients' therapy. First of all, if they're symptomatic, if they're asymptomatic and they're at home, just leave them on their ACE inhibitors, don't touch their therapy. And second, if they come to the hospital and they're symptomatic and everything, just deal with what you have without prejudice against ACE inhibitors and sartans. So that's my
Anyone else have questions for us before we tie things up?
Let me see.
Hey, Jeff, it's Mark McKenzie here.
Positive.
Yep. Yeah, go ahead.
Yep. Thanks. I was just wondering about the initial COVID screen at triage. You said to triage initially to a positive or negative goes to a clean or dirty area. I was just wondering, what triage do you use for that? Because I'm thinking how to separate the COVID people from other comorbidities that, of course, will just have shortness of breath, like someone have congestive heart failure exacerbation. Do they get put into the COVID positive just for being short of breath? What criteria do you use?
My understanding, so this is my understanding from what I read. I haven't asked that specific question, but I thank you for asking. I will ask, and I can send the answer to Jeff, and he will send it. My understanding is that they're treating all the shortness of breath and possible COVID symptoms as COVID, suspected COVID. And like I said, they don't even wait for the test results in the emergency departments anymore. They just try and, launch the patient. They just try and distribute the patient right away. The patient comes. The only patients that stay in emergency department for longer than 6 hours, for longer than 4 hours, is the group that had a slight desaturation after the walk test. Those are the only patients. So yes, clean, femur fractures, all these patients. But for instance, cardiac arrest, they all treat them as suspected COVID.
Yeah.
Right
in fact,
now.
the anecdotal information was that a lot of these patients present actually with cardiac disease.
Yeah,
So
because the
so
cardiac function is limited. Sorry.
There were just a couple other questions maybe that we got by email I'll just touch on. One of them was talking about trying to avoid transporting people to hospital in the case that they were basically in a morbid situation or palliative to begin with, and someone had asked whether there was extended provisions for EMS to declare patients dead on the scene. Throughout most of Europe, the EMS system is very different in that most of the time the ambulance rigs have a physician on them, so they can definitely basically declare the patient at the scene. What does EMS use for PPE was another question we got. At the present time, what we are seeing is that most EMS from the official guidelines are wearing basically what we call contact droplet precautions: surgical mask, eyewear, gown. What type of coveralls are used and how are they washed? In the coveralls that are being used by our colleagues in these non-invasive ventilation ICUs, and I suspect in the ICU as well, I'm not 100% certain, are the disposable Tyvek coveralls. And someone
asked, what is the rate of healthcare provider? I cannot, there's a lot of chats, but I would say this is yesterday's data. I would say 10%.
Well, so it's there. Yeah, 20. As of today, there are 25, or yesterday. As of today, there are 25,000 cases of COVID-19 documented in Italy, of which 2,339 are healthcare workers. So forming about 10% of the infected.
So, but two things, like I said, one thing is most of the healthcare providers were infected in the initial phase. Second, they changed the criteria for testing. It used to be everybody gets tested, even if you're asymptomatic. Now, even if you were in contact with your colleague who turned out to be COVID plus, you don't get tested unless you're symptomatic. There's several reasons. They basically don't have any more, like, it's not like they're trying to ration the tests. And the second reason is they don't want healthcare providers to stay home.
Yeah.
Right.
They need resources.
Okay. Yeah, there's a couple, for sure there's some questions at the more operational AHS level that we're definitely, the two of us are not going to touch.
Amazing.
Okay. All right, so I think we will, unless there's other concerns that are aimed for the two of us, I think we'll probably draw things to a close. We are happy to try, if anyone has specific questions for us, you can reach us by email, that's not a problem. And it's been a pleasure to speak with everyone about our experience.
Oh, thank you. Oh, molto prego.